the idea of the inception of ACT is totally intriguing to me. How you thought, with Marianne Test, how that came about.
Right.
The early moments, really, if you would describe that.
Sure. Actually, it all took place in a state mental hospital, which in the 1960s, there were a lot of pretty awful state mental hospitals around the country. Fortunately, the one that we were working in Madison, Wisconsin, was a relatively well-staffed state mental hospital with wards of about 25 people on a ward with 2 psychiatrists, a psychologist. We had a research unit in the hospital. And so it was...
You were working inpatient at that time?
I was working inpatient at that time. I had finished my residency program, and actually my residency was subsidized by the state of Wisconsin, so I owed 2 years. And so, my eventual plans were to be in a university someplace, but I couldn't do that until I paid my time back, because it's the only way I could afford to go to medical school was to be on the GI Bill and to be subsidized in my residency. So just on another note, I grew up never ever dreaming that I'd ever go to college, let alone go to medical school.
Because your family was not a family of doctors. It was
not a family of money, or that.
Right.
That was the problem.
Right.
So at any rate, I finished my residency working in a state hospital, and I did have an interest in research, and so I eventually worked up to become director of research in the hospital. Marianne Test and a colleague of mine, Arnold Marks, were working on one of the research wards, and they were testing some inpatient models to try to improve functioning. And occasionally patients would get better and they would get discharged. The problem that we were facing in the hospital, not only on that research ward, but throughout the hospital itself, which was an acute treatment hospital, we'd get people who would come in who would be psychotic. We would treat them. We had enough staff and use the appropriate kinds of medications, and we would get them into a non-psychotic state relatively quickly, within a few weeks. We'd make good discharge plans, made sure they had a place to live. We made sure their SSI check was coming to the right address. We had an appointment for them at the mental health center to get their medications when they ran out, because we gave them X amount of meds to last until their appointment. And lo and behold, they kept coming back.
Right. Even with all of that.
Even with all of that, good treatment in the
planning,
hospital, good discharge planning.
Right.
But they were coming back over and over again.
Right.
And that was the situation throughout the entire United States. They were called the revolving door patient. And so we were trying to figure out what was going wrong. We thought we were doing everything right. And part of the research that we were doing was we had social workers who were out in the field following up some of the research clients. And lo and behold, they were reporting back to us that what was getting people into trouble were not the kinds of things that we ordinarily thought about, psychological things. The things that were getting them into trouble where they were running out of money. They'd get their check, and had one woman who had a wonderful ear for music and was always dreaming about buying this particular kind of hi-fi equipment that, to me, I couldn't tell the difference between good stuff and bad stuff, but she had a wonderful ear and could. And one day she passed by the window of a store, and there it was, and she went in and bought it. But the problem was it was the 15th of the month, and so she was out of money. And 2 days later, the refrigerator was empty, and 3 days later, she was back in the hospital. Or somebody would get into an argument with their family, and they would see to it that they got back to the hospital. Or Somebody would get evicted from an apartment and start wandering the streets, and within a few days they'd be back in the hospital. So what became clear to us was if we wanted to help people make it out there, that is to be able to live stable lives of decent quality out in the community where everyone else is living, we couldn't do it in the hospital. Can't be done because the kinds of problems that were getting them into trouble could not be addressed in the hospital. So we then designed a research.
That's step one. Right? I mean, it's like
that was step one.
That you figured that out. It's like many people still are operating under that model you described.
Oh, I understand that.
Right.
Yeah. I understand that.
So this is 70, 72, 73?
Well, this is, early 70s.
Yeah.
I'll, the point you just made is very true, and one that was very vexing for us for a very long time. I'll explain why in a minute. So we decided to test the hypothesis of, well, what happens if you do provide these kinds of supports to people? And we, as Marianne Test and myself and Arnie Marks, we wrote a grant and got funded to do the research to have people who were coming to the hospital randomly assigned to either go in or go into our community program. And our community program was really modeled after a hospital ward.
Right.
We had
hospital without walls.
It was a hospital without walls, exactly. We had psychiatrists and psychologists, social workers, and psychiatric aides and nurses, and we operated like we did in the hospital, 7 days a week, 3 shifts a day. We collected data over a long enough period of time. We did 2 other experiments at the same time because it occurred to us. One was, let's say we're successful and we find that we can actually keep people stable in the community. What are those out there now keeping people in hospitals going to ask us? And one question they're going to ask is, well, you might be able to do that, but the cost is so great that it. So a friend of mine who was actually an internationally known economist, mental health economist, agreed to collaborate with us, and we did a study on the cost of this. And then I saw an article in the American Journal, forgot the specific number, but it was an article that sort of knocked me on my feet off my feet, because what the article was saying is, if you let people out living in the community, there's people with serious mental illness, you may really be causing a lot of illness and problems in the general population, in the families, and
wow.
And I thought to myself, you mean in this free country you're going to keep people locked up because they might cause other people problems?
Right.
So I thought we better do a 3rd study alongside the other 2, which is to measure the amount of family burden we were causing and the amount of community burden we were causing.
Right.
So we were measuring emergency room use, police use, how many people ended up in jails. We were measuring community family illnesses and anxiety levels, and to try to get some measure of community burden. Well, lo and behold, we finished the study. We found that we reduced hospitalizations by 95%. We reduced the revolving door syndrome, which was running like 60% a year, down to 5%. We found that this was not costing any more than traditional treatment, with much, much better clinical results. And we found there was no increase in community or family burden, because we were giving a tremendous amount of support to families and the community as part of our program. So we thought, well, and we published it.
Wow, yeah.
And we thought, well, here we go. It's going to be out in the literature and everybody's going to do it.
Right.
Well, for 15 years, we pounded our head against the walls. We would present, the stuff was well enough researched and well enough documented that it got accepted at conferences. Every conference we applied to, we got accepted to present our stuff. And so we did a lot of presentations around the country. And the results were always the same, which were people said, well, it sounds very nice, but you can do it in Madison, Wisconsin, but you can't expect us to do it here in New York City or Podunk, Indiana, or wherever. It's
Right.
different. Somehow it's
Yes,
different.
yes, that's right. It's in the soil of Madison.
Yeah, right. Is it in the water,
Yeah,
in the
yeah.
soil? What? People in Madison are healthier than people
Right,
other.
right.
Who knows? Who knows?
So you do the study, the results are like spectacular.
Right,
And then you're pushing uphill.
right,
Was there a point at which something broke?
right. The way something broke was this guy in Michigan, who later became actually head of the mental health, Department of Mental Health in Michigan, saw our stuff and said, you know, it makes sense to me, I'm going to try it.
Mm-hmm.
He tried it, and he did it in an experimental fashion. It came up with the same results we did. Then someone else, he published it.
Yeah.
Someone else saw it and said, well, now we got 2 studies, maybe we better try it. Soon there was enough people doing it where the attitude, it was like overnight, changed from, well, you can do it, but we can't, to, you know, everybody's doing it now, we better start doing it. And so it was like clicking a switch. It was amazing.
And that took about
Took 15, 20 years.
15, 20 years. What about all of the research that's gone on since that time? About what are your thoughts about the fidelity scale and you know, what Dartmouth is doing, trying to sort of, in a way, I'm not sure what to call it, but there's a certain precision to the fidelity dimensions. How does that fit with the original idea?
Well, when we first started, you know, there were some things that we knew were important. We knew that we had to have the right mix of professionals.
Right.
We knew that we had to operate certain hours. I mean, that is, you can't just operate 9 to 5 Monday through Friday and expect this thing to work. We knew that you couldn't have tons and tons of patients and not enough staff to care for them, so that the staff to patient ratio was important. And we didn't come up with any hard numbers. Now, one of the things that happened was, as the model began to be replicated in other places, places started to do it on the cheap.
Mm-hmm.
And they weren't getting very good results. But they didn't see it as because they weren't staffing appropriately and didn't have the appropriate hours. They saw it as something wrong with the model. And so that's when people began to think about, you know, we better start thinking about fidelity.
Right. Defining this model.
And defining the model in a way. And so, right, and I think fidelity is very important. The question is, how religious about it do you have to be? And there really is some, I think, legitimate debate in the community of ACT about that. There's some people who are extraordinarily religious about it. I mean, if you don't have it right down the line, you're not doing it. And others are, and I fall into that category, a bit more relaxed about it. The critical issue for me is results.
How assertive is assertive?
If you remember the goal, and the goal is to help that person live as stable a life as possible, with the best quality of life as possible, with the best self-image they can have of themselves as possible. That's the goal. And that's the thing that guides you. And then you do whatever it takes
To get to true north.
to get
That's
to
true
that
north.
goal.
That's your
That's it.
compass.
That's where you want to go. And so the process is really has to be seen as secondary to what you're all about.
Right.
The process is there to help you get to the goal.
Mm-hmm.
And if the process isn't doing that, then you have to change the process.
Mm-hmm.
You manipulate that. So what that means in terms of your questions, how assertive you get,
Yeah.
sometimes you're assertive enough to knock down doors.
Yeah. Right.
And sometimes the best thing to do is send letters.
Right. Or just keep coming back and ask over
Right,
and over again, even if the answer
yeah.
stays no for a while.
Right. But it's
Yeah.
the goal that you have
Yes,
to keep
yes,
in mind.
yes. Do you think that's a similar goal to living independently in the community, just like everybody else, with the supports that people need?
Well, again, you have to individualize it. For me, the ultimate is what you just said. That's the ultimate. The ultimate is being free enough to make your own choices. Can't say it any better than that. But that's not possible for everybody in the world, including you and I. So.
Right. One thing I heard you say when I heard you speak one time was years ago at in Dublin, Trinity University. Remember, it was like a rehab conference, and you said, I've actually just transformed this in my own memory, but I wonder if it's accurate, that for every friend you make, it's 1 milligram less of medication you take. Did you say something like that?
I don't remember saying it, but I believe it's true. I would like to take credit for saying it. So if you were,
I always quote you as saying that.
Okay, if you heard me say it,
Yeah.
I won't deny it.
But what about that? In terms of the social support and the team.
There's no question about that. The more social support you have, the less medication you need.
Can the team be a substitute for social support?
Oh, it is social support.
So it's not a disservice to think of the team as not necessarily in that formal clinical sense, but of supporting a person as a connection to other people.
Yeah, I think of a team as a family. As a I think that of the team and the people that they work with as part of one big family. Conceptualize the person that you're working with as a member of the team. And do that not just in name, but really do it. And let me give you an example of what I'm talking about. You get together to do treatment plans for that person. The team does them if you have a mini team or any way you set it up.
Right.
That person is part of that team. And that person is at that meeting. That your clinical records are open to that person. That person can write notes in the chart. Has to sign it just like everyone else has to sign it.
Right.
But that person is part of the team. And anything you can do to try to help that happen, I think reduces this struggle.
Whose plan is it?
Whose plan is it?
When you started out as a resident and you were working inpatient, you had one view of what mental illness was all about. So here we are, all these years later. Has your view about what mental illness is all about changed over the course of that time?
Well, it has. It's changed, and it's bounced back and forth several times. One of the things that allowed Dr. Marks and myself to even do this kind of work was a result of our residency training, which I'll describe in a minute. And Marianne Test, also, who did work at a very progressive hospital in Colorado, prepared her to do this kind of work. In my residency, I had a very sort of strange residency where what was really stressed was an existential philosophical approach to mental health.
Frankl?
Pardon?
Frankl?
Oh, Frankl was one. Heidegger. I mean, you know, we read the existentialists and Sartre.
May.
And the whole notion was about freedom and choice, personal responsibility. We were very anti-medical in my residency. Thomas Sass was a very frequent visitor. I finished my residency believing that schizophrenia was a way of being in the world, that it was not a disease.
Right. R.D. Laing.
Yeah, yeah, R.D. Laing, right down the line. Now that was wrong, but I mean, that's what I believed.
Yes.
And that helped
Were you
actually.
doing your residency in the 60s, by the way?
I did. That's right. It was a time of liberation for everything and everybody.
Yes,
That's right. That's right. And so it fit with when we went to this hospital of saying, you know, this is not a way to live your life.
Right.
Got to live it.
Right. So you brought the message to the hospital. You already had this message.
We already had this message.
And you brought it.
Right. Right. Well, you know, as
And
time
you still, yeah, tell
as
me.
time is going on, I mean, I've come to realize that
Zoss was not completely
schizophrenia
right.
is a disease, and but it doesn't. That when someone has it, one has to first think about the person as a person who happens to have a disease, and not think about, well, that is the disease. I mean, you know, he is a schizophrenic. I preach never say, you know, never say that. He's a person who has schizophrenia, just like I'm a person right now who's got some spinal problems, you know, so.
But if people have schizophrenia, is their ability to make choices compromised?
I'm sorry?
Is their ability to make choices compromised? Or not always,
No,
or
I don't.
sometimes?
Well,
or how does that, I'm just trying to understand the intersection of those.
No, I think that it isn't their ability to make a choice, unless you mean it in the sense that if you have a certain disability, there's certain choices that are unavailable to you, so that if you are an amputee, if you have one leg, you're not gonna win the marathon.
Right.
All of us have some disabilities that limit our choices.
Right.
And what those choices are, especially in schizophrenia, vary tremendously. I mean,
Well,
so I would assume,
yeah.
you know, when you're working with somebody, you assume that there aren't any limits to choices, and then it's only experience that's going to help
that
you.
defines the limitations.
Right. The principle is you take the person where they are now, and you say, you don't say, now before we can help you, you've got to do this, and this, and this, and this. So we take you for where you are now, and then we begin working with you, and over time, hopefully, we'll be able to do some things together. And that, to me, is practical, it's sensible, it's not exclusive. It's so easy to do it the other way. I mean, you know, there are all kinds of people that you can get rid of just like this.
Yes.
So, now interestingly, that notion has evolved over time. That's not the way it used to be. It used to be, there was a big debate at one time about if you have somebody who is using drugs and has a history of mental illness, there was one school of thought that said you can't possibly begin treating this person's mental illness until they're off of drugs because you don't know what you're doing.
Right. This is the issue of the integrated treatment approach.
Right. And now, you know, I think we're much wiser and understand that you have to take the person where they are and you start where you can. And, you know, we used to set things up for the benefit of the staff rather than for the benefit of the client. Yeah. But I think the present day, I think present day people who are in the recovery field think about recovery as not being cured of your illness. Recovery, I think, is more usefully thought about as a person who sees their illness or disability as not the primary thing in their life and can see themselves being involved in activities of daily living, including some kind of work and involvement with other people, and see themselves as not any different than anyone else who happens to have some kind of a disability.
Right, right.
Now, that whole concept couldn't happen unless you have people living in the community. I mean, you can't think about, at least I can't think about recovery, somebody recovering while they're in a hospital.
Oh, absolutely not. Yeah.
And so I think ACT teams, as we have evolved, have learned that people have much more potential than we ever thought possible.